afternoon, everyone. I hope you're enjoying your conference, and thank you for taking the time. We're talking about genetic testing in general practice, and I'm talking from some personal experience, giving you some pointers and alerting you to some of the pitfalls that I see GPs often step into. Yes, I'm a clinical geneticist. I'm based in Cape Town, and I am an independent healthcare practitioner consulting to Mediclinic Precise. So let's just say these views are my own and not necessarily those of Mediclinic. So these days it's inevitable that when you're interacting with patients, you're bound to be confronted with them asking you questions about genetics and how genetic information can be used in terms of managing their health care. But then I hear doctors say the following: my training never included anything on genetics. So much has changed and I feel so left behind. I don't know what to tell my patients. They also tell me that their patients are doing direct-to-consumer testing, and then they come to them to help make sense of that information, but that as a GP, they don't know what to tell their patients when they are given a 60 or 80-page report. The GP then asks, well, what does this result mean for my patient? And should I actually be using this result to inform their further medical management? GPs also say, I'm not sure who may benefit from genetic testing in my practice, and also what options are available and who I need to refer them to. So you may also say, well, I am actually quite a forward-thinking GP and I'd like to implement precision medicine in my practice, but how do I do it in a sensible and responsible manner? So let's talk about precision medicine. What exactly is it? Because it is a buzzword that has been around for actually 25 years. I saw it was first coined in 1999. So even though it has been around for 25 years, it's still being called an emerging approach in healthcare. So we're still not there yet, but precision medicine aims to use knowledge of an individual's genetic, environmental, and lifestyle to further guide decisions related to their medical management. So what is different in precision medicine than what you may already be using in your practice is essentially the genetics component. But the ultimate goal of precision medicine is to provide your patient with a more individualized and personalized approach for the prevention, diagnosis, and treatment of their disease. And let's be honest, that's what our patients want. They want to be seen as unique individuals, and they want to be treated as such, and they're not satisfied anymore with a one-size-fits-all approach. So historically, if we're thinking about genetic contribution to disease, we're thinking about rare genetic diseases. So these may be things like hemochromatosis, porphyria, Down syndrome, cystic fibrosis, and that's about 6% of the population. That's also historically what I deal with and what gets referred to me. But as we're learning more about genetics, it's currently hypothesized that about 65% of the population will at some point in their lifetime develop a disease that is at least at part being contributed by their genetics. And I'll be bold enough to say that it will probably increase even further to almost all individuals. So you may ask, well, is primary health care actually the best place for precision medicine to be introduced? Isn't it actually something that should be reserved for the very specialized subspecialists, and they can use this cutting-edge technology? But there's actually a number of reasons why primary healthcare is perfectly poised for precision medicine. So primary healthcare is the entry point of most patients into the healthcare system. As primary healthcare providers, you are already focused on the holistic management of patients, and precision medicine slots right into that. You are working with individuals, but also with their families. And when we are looking at genetics, we are not just looking at an individual. We share genes and our environment with our families. So inevitably, when we're looking at genetics, we're looking at families. You are involved in the long-term follow-up of patients and families, often over decades. risk assessment, risk management is very much part of your everyday practice, especially when it comes to preventative health care, so preventing lifestyle diseases, cancer, and then also chronic disease risk management. And these are all areas where precision medicine perfectly slots into. Now, if primary healthcare is perfectly positioned for precision health, why aren't we actually using it? Or why is it not part of mainstream practice? So there's a number of barriers that I see when it comes to implementing precision medicine. And this is over and over the same thing that I hear, is that we do not have adequate training in genetics in our undergraduate or even postgraduate training. And this is true whether you've done your medical degree 40 years ago or whether you did it 4 years ago. Not much has actually changed. And how can we expect our doctors to know how to implement genetics in their practice if they don't have adequate training in this regard? Another massive barrier is the lack of genetic professionals like clinical geneticists and genetic counselors who are there to support primary healthcare practitioners. So currently in South Africa, we have 15 medical geneticists. Most of them are in the academia or in the state healthcare sector. There's less than a handful of us in the private sector. There's currently 6 registrar training posts across the country. It's 4 at Wits, 1 at Stellenbosch, 1 at UCT, and that's it. So every 4 years, we're gaining 6 medical geneticists, and half of them leave the country. Some other barriers are that even though we've made great strides, our knowledge in terms of knowing how to clinically apply, integrate, and interpret genetic testing for most conditions is still limited. And again, this clinical utility is clearer for conditions that are more genetic, so your rare diseases, but when it comes to your more multifactorial and complex diseases, it's still very unclear how do we actually use that information and integrate it into the person's preventative and disease risk management. Where are the guidelines? They don't exist. So we're often faced with genetic jargon, and I mean, there's often a way around it. The first year of my medical training is like learning a new language, wild type, heterozygote, homozygote, allele. You know, it's a different language, and we cannot expect GPs to always know what these things mean. And then when you get that report, you don't know how to interpret it. It's not your fault. And then obviously genetic testing by nature is often complex, and obviously rare disease genetic test reporting will be complex because it is very complex information. But if a direct-to-consumer company is giving a genetic test report to a patient or to a GP, and they don't understand what is in that report, they are doing something wrong. And with that also comes then often transparency from many genetic testing providers in terms of what are the limitations and the actual indications of their tests. So cost is always an issue when it comes to genetic testing and lack of medical aid reimbursement for most genetic tests. We are, of course, faced with our Google doctors, the patient who comes in, they've done their research, there's been new media reports, celebrities. Last year, Chris Hemsworth was in the news, the actor, because he tested positive for ApoE allele, which increases his risk for Alzheimer's disease, and now everyone wants ApoE testing. And the same thing happened when Angelina Jolie made her BRCA status public a decade or so ago. So our patients come with information, and again, it's often things that we don't feel comfortable with. And then, of course, with genetic testing, we can never take away from the ethical concerns and the psychosocial impact that genetic test results may have on our patients and their families. So that also leads into what makes genetic testing different to any other test that you may implement in your practice. So genetic testing is potentially powerful, right? There can potentially be a lot of information contained in that result, and it can change the trajectory of what a patient was thinking their future may look like. A genetic test is also permanent. So unlike a white cell count that can go up or down with infection, or a hemoglobin that you can treat, a genetic test result cannot and shouldn't change. If a patient has a genetic test result which changes over time, that is dubious reporting. So it is supposed to be a permanent result. It is also often predictive, meaning that, as I said, it changes what they think the future may look like. And then, of course, there is the impact, so the implications, so psychosocial, familial implications. A genetic test result is never just about the individual, but also about their family. So let's just quickly speak about genetic variation. Because to understand precision medicine, you have to understand what exactly we are looking at. So if you're looking at person 1 and person 2, person 1 has a cytosine at a specific position, a letter C, and person 2 has a T there, a thymine. So that is a difference between the two. Sometimes we call variants, when I explain to patients, I call it like a spelling mistake or a spelling change. Variants are normal. We all have them. We all have between 5 and 6 million genomic variants that are not necessarily unique in us, but different from the person next to us. Historically, we've used the term SNPs, or single nucleotide polymorphisms, to describe benign or very common population variants, and mutations for disease-causing variants. But these days, often those lines are blurred, and we want to stick to a more neutral term. So we'll talk about variants or genetic changes. So as I said, we all have genetic changes. If you look at these 8 individuals, some of them have the same genetic variant, so some genetic variants are more common. And then some individuals may have rare genetic variants, which are unique to them, or maybe just in very rare variants. And the tricky thing here is to understand, how do we interpret these variants? Which of these actually increase disease risk? Which are potentially protective? And how does that influence our disease? So if we take person 1 there, that is a common variant. We see it in many other people. We know that's a neutral variant, so it doesn't influence risk for disease. If we look at the next variant, it's also a common variant, and maybe we know that that is a variant in the population. It actually reduces your risk for coronary heart disease, for example. But now they have that variant there, which we don't see in anyone else, so it's a rare variant, and what is the effect of that? And that is often where there's still some uncertainty. So if we think of human disease, of the patient coming into your practice, whatever they present with will be somewhere on this spectrum of being entirely environmental or lifestyle in origin, or maybe being highly genetic. So on the highly genetic side is obviously the things that come to me, so your patients with chromosomal single gene disorders like the porphyria, the hemochromatosis, adult polycystic kidney disease, Down syndrome, etc. You also have your hereditary susceptibility to disease or cancer. These would be like your BRCA1 and 2 cancers, for example. On the other side, you have your environmental conditions. So these would be things like trauma, the person who slips off the stairs and breaks their ankle, or malnutrition due to food insecurity in your house. So there's not much genetic risk involved there. But then what you see in your practice is this big group of conditions, the complex diseases, the multifactorial or polygenic diseases, where we know that it falls somewhere on this spectrum. There are some genetic and hereditary factors. That's also why we see many of these conditions sort of cluster in a family. Again, it's not following a very strict pattern of inheritance, but we're seeing it, it's more common in this family. So obviously there are underlying genetic factors, but it's also in combination with their lifestyle and other environmental exposures. So what I just want to show you here is, if we now look at your highly genetic conditions, here you would have a person, so this example is now cystic fibrosis. This person do have variants, and I'm not sure if it projects, but there's little V's all over their chromosomes, so they have normal variants, just like all of us. But on their chromosome 7, there's 2 very disease-causing variants sitting there in the CFTR gene. And that is what is causing cystic fibrosis in this person. The other variants actually have not much of an influence, into their disease risk. Obviously, they're also at risk at other complex diseases, but that essentially is what causes their genetic condition. So if we wanted to visualize that, their underlying genetic variant and their genetic predisposition is the main determining factor for disease in them, whereas other environmental exposures and lifestyle is not going to have such a big effect. If we compare this to our polygenic, multifactorial, complex diseases, so this is your hypertension, coronary heart disease, type 2 diabetes, most cancers that people get, also common things like autism, Alzheimer's disease. What we see there is that an individual you have these variants across your genome. Some of them increase risk, some of them reduce risk, some of them are neutral. And in the end, a bit of a sum total of how all these risk factors even out. So for people with multifactorial disease, we can look at it like a glass jar with marbles in them, okay? And your genetic predisposition is there. You don't have control over your genetic predisposition. For some of us, it will be high. For some of it will be low. The genetic predisposition itself is not sufficient to cause disease, okay? But if you combine that with certain lifestyle and environmental factors, that threshold will be reached. Your glass of marbles will now be filled, and at that point, the individual will manifest disease. So if you look at a population in this normal distribution or bell curve, most individuals are obviously sitting in the moderate or average population disease risk. So you have an average underlying genetic risk for disease. Some are fortunate, they sit with a very low genetic risk, and some individuals are unfortunate and sit with a high genetic risk. And now, obviously, depending on your lifestyle and environmental exposures, it will determine how quickly your glass gets full. Now, even the person with a low disease risk may get there to the threshold, but they can obviously lead often a much more unhealthy lifestyle before they get there. Whereas the person with a high genetic disease risk may not necessarily get disease, as long as their risk factors are managed appropriately. So it's very important to just understand how testing for these multifactorial conditions should be interpreted, in that the genetic predisposition is not as deterministic as often what your environmental influences may be. So that leads me now to, obviously, the more genetic a condition is, the more we are able to use genetic testing to both diagnose and to predict disease. And obviously, the more environmental and the more multifactorial, the less predictive it will be. So this is where it comes now to, well, what genetic testing are you doing? So if we are doing diagnostic genetic testing, like what I do in my practice, we are testing towards the highly genetic side. If your patient is doing wellness DNA tests, I'm not saying they are wrong, okay, but we have to acknowledge their limitations in that they're testing for conditions where the underlying genetic risks or the risk factor contribution to disease is quite low in comparison to some of the other environmental or lifestyle exposures. So the clinical utility and medical actionability of results do increase, obviously, the more you're leaning towards the diagnostic testing side. So know the difference and manage expectations. I just want to mention something about polygenic risk scores. It is a bit beyond the scope of this talk, sorry. But polygenic risk scores is going to be huge. It's going to be something that is going to be part of practice. It's essentially scores or risk scores that have been developed from looking at large genetic studies, so population-based studies, GWAS studies, where they look at individuals who either have disease and individuals who don't have disease. And based on that, they can determine which of those genetic factors are increasing risk and which are decreasing risk. So you can more accurately predict who will be those individuals with common complex diseases that have a high genetic predisposition But what we don't know about polygenic risk scores yet is how do we integrate that into medical management. So if you think about your coronary heart disease patient, you use risk scoring systems. I mean, it's been a long time since I've seen a coronary heart disease patient, but you use something like a Framingham score, for example, to determine their risk, their lifestyle risk, use their cholesterol, etc. Now, they might have a polygenic risk score that says, okay, they're low risk, the Framingham score is high, but now how do you actually merge those two into some, like a combined risk for this individual? And that's what we don't understand yet. But there's a lot of research being done. The other major limitation with these kind of scores is that they've been mainly developed from these GWAS studies, which is in European populations, so we also don't know yet how applicable are they to individuals that are of non-European ancestry. Okay, so let's put this all together into, I have two case examples. Not sure how I'm doing for time, but I can cut it short if needed. So a 30-year-old woman comes to you for a routine pap smear. She mentions that her father's sisters, both the sisters had breast cancer at a relatively early age. He never had cancer, he's now 65. So she said, I've seen a genetic test being advertised. I see it can assess my ancestry and it can also test the BRCA1 and 2 genes. So I'm really worried about my aunt who had breast cancer and that I may also get breast cancer in my 30s. Do you think I should do this test? So I don't know, is there anyone who's brave enough to maybe say what they're thinking? Okay, so what are the pitfalls or potential pitfalls for you as the GP with this case? So it's important to know that not all genetic tests are created equally. And it is very important to differentiate from what is just a fun kind of test which is being offered for informative purposes. And they're not always benign. They can actually sometimes have very significant impact on a patient versus what is an actual diagnostic test. And the other thing that we see in this example is that the lines are being blurred between what is the fun test, the ancestry test, which doesn't have any clinical utility, and doing a potentially quite serious predictive test, which is this BRCA1 and 2 gene test. It's also important to know that limited cancer genetic screening, so just doing this BRCA1 and 2 test, we don't even know what variants are checking or looking at. Some of them only look at 3. It might be Jewish variants, and she's actually of a completely different ancestry group, which means there's absolutely no use in doing this test in her. So limited screening is not appropriate or reassuring. And doing predictive kind of genetic testing without any pre-test counseling is actually quite dangerous. So what are my polls for this case? Is it's best to refer this individual to a genetics professional. And I mean, we can talk about, how that may look. The good thing that COVID did is that everyone these days are doing online and video consults. So even if you're not located close to a genetic counselor, most of them will do online consults. So it's definitely a lot more accessible. Our other what we also always advocate for is if an affected individual, so someone who has had cancer, if that person is available, and again, they're not always available, we would want to test them first. Because if you test an infected individual first, and they test positive or negative for whatever you're looking at, you know that you have what you have looked for. And if you do find something, you are then able to do cascade testing in the family just specifically for that variant. Whereas if you test an unaffected individual for whatever and they test negative, you don't even know if you tested the right thing to start off with. So that is a major limitation and I mean a reason to involve someone who is a bit more experienced. So be very cautious of doing any predictive testing without pre-test counseling. So testing an unaffected individual for a possible disease risk. And also consider potential ethical, psychosocial, and insurance implications. So these are all good reasons to rather refer this patient. So here's another example. So patient visits with her 10-year-old daughter. She says her father has just been diagnosed with Alzheimer's disease at the age of 70. She's extremely anxious about this. She's done a lot of research. She wants to know if you can do ApoE genetic testing for both her and her daughter. Now, ApoE is a gene that is involved with the transport of apolipoprotein E. It has been associated with the increased risk for Alzheimer's, but currently none of the international organizations like the American College of Medical Genetics and Genomics or the National Institute of or Society of Genetic Counselors are advocating for ApoE testing in individuals that are unaffected. And that is because of the limited ability for us to actually show that knowing your ApoE status is something that can lead to a risk-reducing activity. What are you going to do about this? So it's easier for something like a breast cancer risk is you can do more intensified screening. What do you do if you have an increased risk for Alzheimer's? Even more so, what does this information actually help your 10-year-old daughter? So be very cautious of genetic testing for neurodegenerative conditions where there's limited clinical utility and medical actionability. And then also be very wary of genetic testing in minors, especially for your adult onset conditions. So generally it's a big no from me. So remember, the benefit must always outweigh the harm. We don't want to do harm, and always respect your patient's autonomy, and especially the autonomy of kids to actually make those decisions themselves when they are at the age to do so. And I just want to mention, I saw a company advertise on social media a picture of a very cute little baby and say, it's never too early to screen your genes, have your baby tested now. And I just thought, again, you are screening in more the, wellness kind of range, but surely that child should have some say in whether their genetic, material gets analyzed. So as I said, be very cautious of any form of predictive testing. Rather refer to a genetics professional, especially when minors. Educate and inform your patients. I know it doesn't always translate to them doing what you are recommending. They still often go off and do their own thing, but at least you have informed them. And always consider, is there benefit versus what is the potential harm of this test? I just have one slide on genetic counseling. Many people don't know, what actually happens during genetic counseling. So in genetics, there are two main genetics professionals, or in clinical genetics. So you have a clinical geneticist, which is someone like me with a medical degree that have specialized in genetics. And then you have genetic counselors who often come from a BSc science background and then do a 2-year master's program in genetic counseling. So I'll often say, if you don't understand it, maybe compare it to like a psychiatrist versus a psychologist. So the one can diagnose conditions, manage maybe more complex conditions, etc., whereas the genetic counselor is more than able to do, standard kind of counseling where there's already a diagnosis, and they're actually very good at addressing psychosocial concerns in a family. So often the word counseling also put people off, like I don't need counseling about this, but it's actually just a discussion and a session where we give information and explore why you want to do this test and what the possible outcomes and implications may be. It's also very important in terms of selecting the most appropriate test. And then of course, when it comes to genetic testing, often advanced interpretation skills is required and correlation with your patient in the end. So this is my last slide. So what do I see as the role of the GP in genetic testing? And again, often some GPs may feel, more empowered to take on more, but maybe one can just work towards this. Recognize who may potentially benefit from genetic testing or testing for genetic predisposition to disease, like that person who has a family history of cancer, etc. If you feel uncomfortable or unsure, rather refer or consult with an expert. And then I also say just educate and advocate for the differences between diagnostic and wellness type genetic testing. I'm not saying one is wrong and one is right, but there's clear differences, and I think it's important that patients also understand the differences and what the impact of that test may be in terms of using it to improve their health care. So thank you very much.